So I want to kick this off with Dr. Al-Qureshi, and I want you to just feel free to share your bio and then take a dive into your work.
Cool. Can you guys hear me okay? Yes. Awesome. And call me Lolita. Okay. My patients don't even call me Dr. Al-Qureshi. I say, my name's Lolita. You can call me that. So thank you for the invitation to come and speak. I'm thrilled on behalf of my team to kind of share a little bit about what we've done and why we think it's important. Clinically, as you mentioned, I work in a federally qualified health clinic in the south side of Chicago. So most of my days I'm speaking completely in Spanish, which actually was my first language. We see a lot of underserved, mainly Spanish-speaking patients at my site. I've been there now, I think, for about 11, going on 12 years, and I love it. It was so nice to hear some of the comments about how important that longitudinal relationship is and how important that is in trust in my patients, trust that they trust me, and kind of forming that relationship. So for me, it's the joy of my practice, and I enjoy my little clinic. As an academic at the University of Chicago, my interest research-wise is in the EHR, the electronic health record, and how that impacts the patient-doctor relationship and communication, and how we can make that a better experience. How can we leverage something that gets a lot of bad press, particularly on the side of clinicians? We're charting in it after hours. We call it pajama time when you're at home with your laptop finishing your charts, when you really want to be, with your kids eating dinner together. So there's a lot of negativity on the provider side about the EHR, and there's some negativity on the patient side as well. There's this new third kind of entity in that patient-doctor relationship, and how can you make that a positive? My interest in this project was born back in 2011, and that's when my clinic was transitioning from paper charts to the electronic health record. And I trained as a super user, which meant I was facile in how to use the system before my colleagues were. And for an entire month, all of my clinics were canceled, which was weird. It was a weird out-of-body experience. And my only job was to kind of flip through the clinic and help my colleagues navigate this new thing that had been thrust upon us. And what I saw was really interesting. What I saw was, and I'm not sure if we have the PowerPoint, the graphic, but there's a slide.
I can get the pointer for you.
And I think what I saw is what this little 7-year-old girl captured so eloquently. This was a drawing a 7-year-old girl made of her trip to the pediatrician. And that's her and her mom and her sister facing each other, active, engaged, and that's the poor pediatrician off to the side, back to the patient, missing really important verbal and nonverbal cues. And that's what I saw. I saw my colleagues, seasoned communicators and clinicians, really failing at this in a miserable and painful way. And it was not a patient-centered interaction. It was very much a computer-centered one. And it's what inspired me and our team to really think about what is the impact of this thing on that patient-doctor relationship and communication. And that's what motivated that literature search that's in your guys' packets. And what we saw was a large number of studies that showed exactly this. Back to the patient, conversations that were dictated by the template, the questions in the computer, and the way that they were laid out, rather than having a natural conversation and kind of integrating it in as you need to. Long silences of typing that were just awkward, and negative behaviors that could potentially impact the relationship. There was a group of small but inspiring studies, though. And those were most important to us because they actually asked the patient's experience. A lot of these studies were observational, so a researcher in the room recording those seconds of silence, and that's all well and good to define what the problem is, but what really matters to us is what's the patient's experience. And when we looked at those studies, there was a small but encouraging number where they thought it was better, that the EHR could be used as a tool to facilitate understanding, showing your cholesterol and graphing it, showing your x-ray, using different patient education tools on the computer. And so that's what really motivated us to figure out how can this not be a negative? How can we flip this and make this a positive so that we're using it to engage our patients and to enhance kind of the experience of care? And so what we set out first was just to kind of put best practices together, and this is the little card that you guys have at your table. And it's a short little mnemonic, human level, and I won't go through the whole thing, but I'll just mention kind of two of my favorite, and one is what the last panel kind of talked about, which is honor the golden minute. So when you make your entrance into the room, don't make a beeline for the computer and start logging in and touching that. Make the first point of contact your patient. We called it the golden minute, not necessarily actually meaning for it to be a golden minute, but it sounds like 48 seconds is really what you need. And so asking your patients, what brings them in? What can I do for you today? What is important that we need to address today? I may have my own agenda that I know I need to cover, but open it up so that you can address that first. And then you, for example, is use the triangle of trust. So position the computer screen in a way that your patients can see it so that you can engage them. In some of my clinics that I work, the screen is literally bolted on the wall. You cannot move it. So the EHR is very much an afterthought. It was not ergonomically designed in most of the situations that we practice care. It's an afterthought, and it's basically put wherever there's a plug, and it's usually in the worst area you could possibly put it. So in these rooms where I have the screen bolted, move what you can move. And I'll say, why don't you scoot your chair over here? I know, let's get a little close, but I really want to show you what's going on with your BMI or your cholesterol or whatever it is. And so we use this set of best practices to kind of build out a curricula for our trainees. We start teaching this to our second-year medical students. We continue it through their years. We've integrated into our training for residents. We've offered training for faculty on how to use the EHR. So we're all, as clinicians, we're all trained how to use it, the clicks, this is how you place an order, but very few places dedicate any time to actually thinking about how do you use it with patients. And so we thought we were pretty cool, and we did that, and that was novel. And then it hit us that we were missing two really important groups from this conversation. One was the busy clinician that was not coming to our optional 4-hour training on this. Bad them. And because they were in clinic seeing patients. And then the other one was the patient. We weren't engaging them in this conversation. What is the EHR? What's your role? How can you get involved? And so that's what led us to this comic work. And so we worked with a graphic artist at Northwestern, and we put together 2 comics. One was for patients, and that's Computers in the Clinic, Your Role. And so it introduces them as to what the EHR is, encourages them to become involved, and my favorite is call for attention if you feel like your provider's more focused on the technology and not you. And then we created one on the flip side that's for providers, that busy clinician, really grounding kind of the comic in the patient experience. Which would you prefer? Put yourself in the role of the patient. How would you want that clinical interaction to go? And we studied it. So the clinician comic, knowing that they're busy, they're not going to come to our training. What we did was blew this up big size and put it all over their work areas. It was in their charting rooms. We had posters. They were on their desk. They could not escape it, and that's what we did. And then for the patient one, we passed it out as folks were registering for their appointments. So we studied it in our peds primary care group and our adult medicine group. And we saw some pretty cool results. Nearly 3/4 of our patients thought that this was an effective means of encouraging their involvement and them actually getting involved. Nearly half thought that their provider was less distracted at that visit compared to before. Same rates, almost half felt they understood more about their care or their child's care and the plan, and were more satisfied with their relationship with their physician, which was neat to see. Just the act of handing this out and putting it up could do something. But I think most interesting was we saw really significant differences in 3 really important groups. Minorities, those of lower educational attainment level, and females were more likely to feel empowered and to practice some of these behaviors than their counterparts, which I think is important because, as you all know, these are populations for one reason or another that may be vulnerable, that might not know this is your right. You can get involved. It's okay for you to ask questions. And I think one of the most telling quotes we got when we studied the comics was from one patient who said, "It was really good. I wasn't sure if you could ask questions," which blew us away because that gets beyond the EHR. This is just basic stuff. This is a fundamental component of a trusting relationship. And the fact that this almost served as a formal invitation, particularly for these groups, to get involved, to call for attention if they needed it, was a cool thing to see. So, plus the comics are neat. When we were passing them out, people would come up to us and say, "I didn't get one of those. Can I get one?" And so, comics play an interesting role in medicine. It's been studied in different venues, and I think they're a really powerful educational tool, particularly for diverse populations, different health literacy levels, which is what we have at the University of Chicago. So it's a little bit about our stuff.
I would imagine as we become, again, not calling anybody out, but lazier readers, right, with social media and Facebook, I think we're increasingly appreciating just being taught things in short snippets and in very easy ways. So yeah. I'm going to pass it over to Jermaine, and then we'll do kind of a deeper dive into the threads that wind through both of yours. But Jermaine, would you like to tell us a little bit about your research and your work?
Sure. First, let me just say thank you to Gwen for the invitation to speak and to be with you today. And I also thank you. I also just want to give a quick disclosure that I'll be speaking from my own behalf and not on the behalf of the National Quality Forum. Much of the work that I'm doing right now at the National Quality Forum is around quality measurement. Right now we have a big project that has recently started with CMS to develop a maternal morbidity and mortality framework. So I'm leading that effort at NQF. I also have a role at a think tank here in DC called the National Collaborative for Health Equity. And it's very interesting currently as we begin to look at disparities and health equity and how we can have an impact on reducing and ultimately eliminating disparities. I think it's a really good time to have these kinds of conversations. So I'll just pause for a second there and then back up and give a little bit of, more of my background. I'm a native Tennessean. I'm a proud father of 3, 2 daughters and a son. My oldest daughter is a 9th grader in high school, and she's given us the blues, but she's such a great student. But I remember what it's like to be in 9th grade, so we're trying to take it easy on her. So I always start by saying that I'm a proud father because it really does mean a lot to me to have 3 healthy children and to have had 3 great birthing experiences. And it lends itself to my work professionally and personally. And I do have a significant amount of passion for reducing disparities, and so much of the work that I do and have been doing is grounded there. So I have a couple of slides, and I don't know that they really matter. I really just want to talk and just share information and speak from a personal perspective, speaking about my experience 3 times with having 3 children and being there with my wife every step of the way and playing a significant role. So what I typically do in these kinds of conversations is I lead with the importance of men's health in maternal and child health, because I think we often forget that it takes 2 to make a baby, and we often forget that men and fathers play a significant role in making sure that those pregnancies go well. We haven't been doing as well as we can, but I think things are changing with the help of the maternal and child health community, and being open and receptive to having the conversation about what men bring to the table, what expectant fathers can do to help provide support and nurture the pregnant mom or partner during pregnancy. So there are some evidence-based strategies, and I'll speak about those in just a few minutes, but it's also important that we talk about the research and the policy and the clinical practice barriers, because there certainly are. And when you talked about how important it is to have the relationship between the provider, that's significantly important for us. So I like this slide. I took this picture in South Africa, and it reminds me that, you know, in order for us to have a true impact, we can't do it all at once. We have to take small bites and try to do the best we can. It's one of my favorite slides. In 2008, I was fortunate enough to receive funding from the Office of Minority Health to convene a group of really smart people to look at the literature, look at the data around what role men and expectant fathers play in pregnancy outcomes. And ultimately, this group was more of an agenda-setting body. And if you can see this, it's called the Commission on Paternal Involvement in Pregnancy Outcomes. And ultimately, we developed about 40 best practice recommendations. And those recommendations were in research, policy, and clinical practice. And I still think they're quite relevant today. Just to give a few, one of the most important ones is that we need a national paid maternity and paternity leave. And as you know, Europe's crushing it on this, and we're far behind. And we think that there are some significant things that we can do if we are allowed to have that time off with our newborn. And there's some research that indicates that that time off does help improve outcomes ultimately for the newborn. We did define paternal involvement in pregnancy outcomes as well in that report, because we didn't see much in the literature at that time. The report came out in 2010, and then we later published a paper in Ethnicity and Disease called Where is the F in MCH? It's been widely cited. I think it's important because we tend to not remember, as I said, that men and expectant fathers play a significant role. Men's health is important to maternal and child health outcomes, and I think that we can honestly say that men die quicker than women. We've seen some deaths in the recent past for men, among men, mainly African American men, and we know that African American men tend to die sooner, almost 10 years sooner than women. So that's a particular issue. So let me just go back. I don't know that I can go back here. Okay, so one of the reasons why I think men's health is important, is because of our global rankings. And as you know, the March of Dimes report card just came out, and I think DC got a C minus. But nationally, we're not doing well. I think overall in the U.S., we got a C on our preterm birth weight rankings. Low birth weight is also a significant issue as we look at maternal and child health outcomes, but we know that there are significant risk factors for men's health, and we know that men are important players in the community and in the family. And so just to outline some of those risk factors here, it's really about where you live, what you're exposed to, and much of that really speaks to how men are raised, whether or not they have male role models and strong role models in their communities and families, and that plays a significant role in terms of how they eat, how they address health, whether or not they're happy, whether or not they're surrounded by people who love them and have the opportunity to thrive. And so those things are important, and I don't know if you can see this in the back, but just to outline, there are contextual social determinants, individual social determinants, and then adverse health behaviors, and we know what those are. And one of the biggest things that I think is important to remember is that young boys are often lost to care in early adolescence and tend to not get back into care until really pregnancy for young men, unless they're playing a sport or unless they have something falling off and need to see a provider. I like to joke about it, but it is very serious that we don't have a medical home for many young men. And I remember when my wife got pregnant, I wanted to know more right away. I wanted to know about my blood pressure. I wanted to know what my weight was when I was attending those prenatal care visits with her. And so just a little bit more. This is a paper that we published about 4 years ago in the American Journal of Public Health that speaks to the lagging life expectancy for African American men, and I'm happy to share that with you as well. Just to get to the meat of the conversation about the issue of trust. And I'm showing this slide here because I want us to remember that as we are experiencing all of our adverse health outcomes for African American women and families, there's also a significant amount of disparities that are happening among African American men, and that our sperm count is decreasing, and it has been decreasing. And we might be in some significant trouble, and there are some really good folks at NICHD who are studying this and looking into it. But let's skip through, because I want to talk specifically about the life course perspective and how that in turn translates to the clinical aspects of prenatal care, particularly knowing that men and expectant fathers don't really play a role during pregnancy. Even in the preconception period, there's nothing targeted for men to be healthy, to think about all those risk factors. So at the prenatal period, if you, how many guys, let's see, I see some guys in here. How many of you are fathers? Raise your hand. Okay. How many of you attended your prenatal visits with your spouse or partner? Okay. Did you feel like you had a role? Did you feel like you knew what to do? Did you feel like you were welcome? Were you received? Did you feel like there was material targeted for you to help you understand, to answer any questions? Raise your hand. You did, okay. And so I think that's a good question to ask, because oftentimes men don't have a role. We walk into the prenatal visit, and it's tough for providers too, because they don't know who's with them. So I think there's a delicate balance there that we have to be cautious of. Who's here with you today? It could be an uncle, it could be a grandfather, it could be a friend, it could be a cousin. So those things are very important as we think about what role the providers play. But oftentimes we don't have young men who are going into the prenatal visit don't have the opportunity to feel welcomed or ask questions. And so we've developed this life course model because we think that there are significant trajectories and turning points that help men, young men along the way, think about their reproductive life plan, and gets them to think about how they can become involved in their own health so that they are ready and that they are interested and engaged more so. So that's why I think this slide's important. And these are just some key concepts. So I'll leave this up for just a second, but just to add a little bit more, I don't know how much time I have. I haven't seen a flag yet.
I don't think they're monitoring individuals.
Okay.
Just
Okay.
us as a group.
You
Okay,
talk.
so
You
let
say what
me
you
just
need to
speak.
say.
Let me just continue to speak again from my own perspective, and tell you why I think expectant fathers are so important to improve maternal health outcomes. My wife and I were fortunate enough to have a chance to interview several providers. And let me also just say that I think normal pregnancy should be with a family physician and then working through an obstetrician or a midwife if necessary. Because the family practitioner can provide care, should provide care for their entire family. And if he or she is very good, they're going to be monitoring the health of both the young man and the young lady before pregnancy, and talk about preconception health and care and include that in the care. So I think that's probably number one. But what I think ends up happening is that providers are not always trained to know how to address and include expectant fathers. So there's a little bit of a disconnect there. And it's tough because I don't know that there are any particular training modules, didactic training for obstetricians, for residents to really have a protocol on how to address a couple and speak to the young man or the expectant father. So for me, that's important. When my wife and I became pregnant, we were fortunate enough to do hypnobirthing. I don't know, how many of you have heard of hypnobirthing? No, just one? Oh, okay.
Just you.
Okay. So hypnobirthing is really interesting. It really is something new to me. It was new to me. But basically what they say to the young man or father, expectant father, is that you are supposed to be the gatekeeper. You're supposed to protect and make sure that nobody gets to your wife or partner during, particularly during childbirth. So you're responsible for making sure that you're not going in there hungry, right? That you haven't had food in days. You could have been at home just waiting to be fully dilated, and you get to the hospital and you haven't had anything to eat in 6 hours. So your responsibility is to think through all those things in the beginning to make sure that you can provide the necessary support as the gatekeeper, and to make sure that you are ready. And so what's often also challenging is that young men and expectant fathers have no idea what to do. You might have had the chance to go to one of the classes or a few of the classes and say, yeah, I know how to put the child seat in, but it's a lot more than that. So I think with regard to the patient experience and the trust issue regarding the provider, I think that the expectant father, can do a lot better to build that bridge of trust and take time to speak to the providers. And big shout out to the doulas, because they are so important. They often do provide that gap. They help to close that gap and say, no, you can't leave to go get some food. You have to stay right here. I'll get the food. Because we're not thinking, we don't know, we haven't been trained. And providers can do that. Shout out to the midwives as well. because they are also really increasingly doing more and more to help, I think, young men understand. And I keep saying young men because I know that young men are having babies much earlier, particularly in this area. But I could keep going, but I don't want to do that unless I'm asked to do it. So again, I like to have a little humor and keep it light because otherwise we get bogged down with the disparities and we tend to, become depressed. And there's so many other components to it. There's the postpartum period where the provider can also bridge the gap with trust regarding how to relax and how to take time off, if you can, between the new parent. So I'll stop there, I guess. I don't know if I really did my job, Gwen.
That was great.
Is that okay?
You did great. And I heard two threads throughout both of your presentations, and I'm going to pull on them one at a time. So the first, I want to talk a little bit about the importance of trust to health equity. Now, I know you both mentioned groups that were underserved either because of language barriers or because there were other clinical barriers, health disparities, and the importance of trust in reducing disparities, because I don't want trust to be seen as a luxury that only well-prepared, articulate and good patients have the luxury of having with their provider. I really want to hear from you guys how the importance of trust to reducing health disparities and increasing health equity, but also I think specifically the provider's role in facilitating that trust.
Yeah. So, we conducted a study looking at what our patients think at the University of Chicago, and some of the worrisome comments with respect to the EHR and how that impacts that relationship and that trust. One that stays with me is somebody said, I don't think my provider's on Facebook, but I'm not really sure what they're doing with the computer. I was like, oh my gosh. I really hope they weren't on Facebook, but that it's this thing that's there. And if there isn't this transparency in terms of what it is, how you're using it, what's in there, there can really be this disconnect. And if you show that, you could facilitate questions. Let me show this to you. That can go a long way to breaking down kind of that physical barrier and using it to promote engagement, to promote trust. There's really interesting literature showing that these populations, vulnerable populations, lower literacy level, lower socioeconomic status, minority patients, females, feel more empowered when they can see what's in their EHR. So, people, we mentioned, Dr. Google, but folks go to the internet. They're reading blogs. They're reading medical stuff on Facebook. They're getting information from sources that might not necessarily be trustworthy. And so having a physician show them, listen, this is a website that I trust. This is an app that I recommend. Let me show you why. Using these tools that we have, there's so many tools that you have, not just in the EHR, but in the internet itself that you can use to facilitate engagement and education. And once you start to do that, once you start to understand who your patients are, what do they need, what are their barriers, what are their resources, how can you tap into that? I think that's where you start building the relationship and you start building a healthcare plan together. And I think you can use the EHR to do that. It's their notes, it's their information, it's their medical record. So finding ways that you could jointly create this narrative together and using that to create their chart and planning next steps in their care. And even outside of the actual visit itself, we have patient portals where you can go online and send your physician an email, extend the conversation, tap into other members of the care team. I think as providers, we proactively need to see this on the door, as we're running off to the next patient to think, okay, in the busyness of charting and this and the billing, I need to look for ways that I can use this to build that trust, to enhance understanding, to really get at shared decision making. And it's fun. It's fun finding like different websites to use, and we'll co-create the after visit summary, and I'll show my little patient, see that? That's your name, and it's fun. And I think, you know, as clinicians, we have to look for the fun in our work, and our patients enjoy it too. It just takes an extra step to put yourself in that frame of mind to look for these opportunities, because they're there.
Jermaine, you spoke about this when you were talking about young African-American boys being lost to care and potentially trust either in providers or trust in the system potentially being a barrier facilitator to that, and really reducing the disparities there. Jim, expand on that.
Yeah. Some time ago, I think we realized that just because you have a health insurance card doesn't mean you're going to get and receive equitable care. And so I think there's an issue of implicit bias that we need to be thoughtful about. And I think California is requiring implicit bias training for all of its obstetricians, I think I saw a couple of weeks ago. So with that, I think we have to be thoughtful about how providers are perceived. And at the same time, I think we have to be thoughtful about sort of how most appropriately to reduce the barriers or the access barrier. So I'm thinking, you know, if your obstetrician or midwife says, here's my cell phone number, call me, text me at any point if you have any trouble, I think that immediately lets down the wall between the patient and the provider, particularly for a couple that might be in a high-risk profile with having a preterm birth or low birth weight. I think that's probably very important. And just thinking about how much more comfortable you'll feel if you know that you have immediate access to your provider and they can answer any questions or respond to you. I think that's certainly something that would help.
The other thread that came out, and I think you guys both covered it pretty well, but I just want to highlight it for the audience and for the group, is really the need for training providers around this. I know we've had some offline conversations, and I have personal experience that providers are not taught this in medical school. There's not great skilled communication training. There's not deep training around patient engagement. You even mentioned, Lolita, that they teach you how to use the EHR, but don't actually teach you how to interact with your patient while you're using the EHR. So I just want to highlight, I think one of the gaps and barriers to some of trust really is effectively training providers and those that are working closely with patients around issues of trust. Before we open up to audience Q&A, do you guys want to add anything around that training aspect?
Yeah, when we did our initial literature review, there was only one study in that whole bunch where they were providing that training, and it was at Kaiser, which, you know, is a really forward-thinking organization, but it was just there. And so I think it's really important that that becomes part of accreditation of a medical school. When you get your license, ongoing kind of training, it's critical. And what we saw is it can't just be at one point. You know, you need to have various touch points where this speaks to you as a medical student, as a resident, as a practicing physician, because if it doesn't continue, then it's not going to happen. And we saw that when we trained our second-year medical students. We gave them, you know, their laminated card, and we trained them, and we threw them into a simulated patient encounter. They did awesome, and they rocked it, and we compared them to our third-year medical students, so one more year of training and experience, and they didn't do as well just by nature of having the training. We thought, wow, we nailed it. And then we followed our second years when they grew up, And as third years, they regressed. They were just as bad as, had they gotten nothing. And so I think it's really important for organizations to support this as, something that's mandatory. The EHR is here. It's not going anywhere. And you could have an opportunity to enhance the patient experience. And vice versa, you could really destroy it. So I think it becoming part of a mandate is just super important. I didn't get this kind of training in terms of what is the FOB, the father of the baby. Like, not even a name. You get 3 letters. And it's important.
Yeah, I agree. I think it could be included in didactic training and then followed up with a social epidemiologist and looking at competencies as well as they matriculate through. I think that'd be key.